And now we have time for 2 questions for Professor Dr. Hisham. Okay, thank you, Hisham.
Professor Hisham Al-Ghazali, thank you very much giving us what's happened last year in this meeting and give us an idea how this meeting will be active and interactive, and you invite everybody to share in an active discussion. Now we have the next speaker, which is a very famous name, and I have the honor to introduce Professor Christophe Girard from the USK. Professor Christopher Girard is a professor of Department of Gastroenterology, Medical Oncology, Division of Cancer Medicine, University of Texas, MD Anderson, a very well-known center dealing with cancer and new guidelines. And Professor Christopher will deliver the topic titled Choice of Treatment in Stage 2 Colon Cancer. When should we treat? Okay, so please, Professor Christopher.
Assalamu alaikum. Good morning. Thank you very much for inviting me this morning to your country. It's an amazing country. It's a very ancient country, but I also realize it's a very young country. And I want to thank Professor Hisham and Professor Osama for inviting me. So as you heard this morning, let's see, how do we advance here? So as you heard this morning on the video, we've improved in our cancer care, and we're now curing over half of the patients with cancer. In stage 2 colon cancer, we're faced with a unique problem in that the vast majority of patients will be cured with surgery alone. Now, we do have randomized controlled trials that show benefit for patients with the use of adjuvant chemotherapy, but the benefit is relatively modest. So the goal is looking at selecting the patients and identifying the ones most likely to benefit. So as you know, for stage 3 colon cancer, there's a overall 20% benefit with the use of chemotherapy. But in stage 2 colon cancer, that benefit is less than 5%. So overall, it's a favorable group. Now, one of the reasons this makes it difficult is because so many people are cured and follow-up is for a long period of time. Overall survival tends to be a very good endpoint generally, but here it can be confounded by non-cancer mortality. And in fact, in the original North Central trial, there was an imbalance in the non-cancer related deaths, and that may have obscured any benefit from the use of adjuvant chemotherapy. We also would like to try to identify better the patients at greatest risk of relapse, those that perhaps have a prognosis most closely akin to stage 3 colon cancer, and therefore would derive the most benefit. So here are the trials that have prospective randomized controlled trials looking at stage 2 colon cancer. These are subgroups of larger trials. The first trial I mentioned was the intergroup study, which was performed centered at the Mayo Clinic and did not show a benefit to the use of adjuvant 5-FU and levamisole. But subsequently, the CO2 trial, the North Central, the National Surgical Adjuvant and Breast Program trials did show a benefit, and we have a large British study, the Quasar study, which did show a benefit, albeit it was a 3.6% benefit at 5 years. So when assessing a patient, initially we first look at the pathologic characteristics, and after that we're then looking at different molecular characteristics, including single genes, and now more commonly multi-gene panels are becoming available to help us with prognosis and in some cases with predictive efficacy. So for 5FU, in terms of predictive of efficacy, I'll talk briefly about microsatellite instability analysis as a negative biomarker of 5FU sensitivity in those who have microsatellite unstable high tumors. And I'll just mention the evolving role of KRAS and BRAF. As you know, there's some data now, and there's for PI3 kinase mutation as a predictor of aspirin efficacy. So for pathologic characteristics, patients with T4 or full penetration thickness, there are 2 retrospective studies and 1 prospective study that show a significant adverse prognosis. And in fact, the magnitude of prognosis, although we can't compare it to stage 3, the magnitude of prognosis would be roughly between that of stage 2 and stage 3. And in fact, in rectal cancer, where they looked at T4 N0 lesions in the North Central pooled database, they actually had a worse outcome as compared to T3 N1. So there is situations where stage 2 colon cancer may have as poor an outcome as a stage 3. There are retrospective studies showing that perineural invasion particularly is associated with a worse outcome, as well as lymphovascular invasion. Now, having said that, in all of the studies so far, when they've looked at these factors surrounding chemotherapy, they've not been able to show that chemotherapy improves the outcome for these subsets, in part because of the dilution of the power with subset analysis. So for differentiation, it's important to note that high-grade tumors or poorly differentiated tumors have a worse prognosis only if they're microsatellite stable. Tumors who are microsatellite unstable that are poorly differentiated have the same prognosis as moderately differentiated tumors. There is a continual variable of outcome based on the number of nodes sampled, and the lesser number is a worse prognosis. This is complicated. It may indicate suboptimal surgery, but in some cases it also indicates the immune response of the patient, and this alone may be a bad prognostic factor. So there's no uniformity in cutoff. ASCO guidelines is less than 6 lymph nodes. We have a National Cancer Center panel network that says less than 13. So we routinely at MD Anderson now are staining all tumors with immunohistochemistry for microsatellite instability analysis, and that it's about 90% sensitive for patients that highly suspicious that they are MSI high. Doing both by PCR and immunohistochemistry increases the sensitivity to 97%. It's important to note that about 15% of colon cancers are microsatellite unstable high, but of those, 2/3 will be due to hypermethylation of the HMLH1 gene, and only about 5% are familial or hereditary colon cancer. There's some controversy as to whether patients should be selected based upon pathologic features and a family history, or whether there should be universal testing of all samples. You can see here, these are the different recommendations of the different panels. So they have looked at testing, and you can obviously increase your detection rate if you do universal testing of all colon cancer samples, but you'll also end up having to do more germline testing, and that'll increase the potential cost of this intervention. However, I'll say we've decided at MD Anderson that all new cases diagnosed MD Anderson will have immunohistochemistry. So if you look at, initially this is a study, and this is a pooled analysis of specimens from five retrospective pooled analysis of 5 prospective randomized phase 3 trials. And they did the analysis by PCR. You can see here, because of their definition of microsatellite unstable, where they would allow even just 2 microsatellite loci, that they had a higher percentage of patients with microsatellite unstable disease, and particularly significantly higher in stage 2. But this analysis looks at both stage 2 and stage 3 patients. But in the top panel, you'll see that for patients who are microsatellite unstable, that there was not a benefit seen to chemotherapy. And in fact, there was a suggestion that there was an adverse effect for the use of chemotherapy, whereas the microsatellite stable on the bottom panel had the expected benefit from 5-FU chemotherapy. And it also, for patients who did not receive chemotherapy, this study also showed that this was a prognostic factor independent of stage and differentiation. So they looked at combining this data set with about 400 tumors from the North Central, the French group, the Italian group, and this would allow over 1,000 samples and would allow separation of stage 2 and stage 3. And this showed that for microsatellite stable tumors in both stage 2 and stage 3, there was the benefit to adjuvant chemotherapy was maintained, but this was not seen for microsatellite unstable. And as I mentioned before, there was actually an indication that patients who were treated who were microsatellite unstable had a worse outcome with the use of chemotherapy. So you can see here that for on the top panel for disease-free survival for microsatellite stable tumors, there was sorry, I apologize. This is so for stage 2. The top panel should say microsatellite unstable tumors. That for surgery alone, they had a superior outcome. On the top left, inferior outcome with 5-FU. Now, having said that, I'll just mention that in the Quasar trial, they did look at patients who are microsatellite unstable. And in the Quasar trial, there was a statistically significant benefit to 5-FU, albeit small, for microsatellite unstable tumors. But in most of the retrospective studies that have been done now, they've validated that this is an independent prognostic factor, also a negative predictive factor for 5-FU efficacy. So obviously microsatellite unstable tumors are a heterogeneous group of tumors comprising both hypermethylation as well as hereditary colon cancer. And this is a study from the NSABP looking at combining BRAF mutation, which occurs at higher frequency at microsatellite unstable tumors. And you can see that patients who had microsatellite unstable high but wild type BRAF did better than those with mutant, and similarly this looked the same for microsatellite stable tumors. Now this is early retrospective data, and we're not now routinely recommending KRAS or BRAF analysis in patients with stage 2 colon cancer, but this is something that may be fleshed out in further studies. So right now, the recommendations for our NCCN pilot guidelines are that they should do mismatch repair testing for people under 70. And the patients who are MSI high should not receive adjuvant chemotherapy. So as we mentioned before, this is the largest randomized prospective trial demonstrating a benefit to adjuvant 5-FU chemotherapy, albeit a small benefit. And as I mentioned earlier, that benefit was held up even in the patients with microsatellite unstable tumors. So based on this and based on meta-analysis, generally we recommend that a discussion is had with patients regarding the small observed benefit in clinical trials having to be weighed against comorbidities that a patient has, as well as the patient's expectations of benefit and their perception of toxicities. It's not routinely recommended for all patients, but patients with high-risk pathologic features, it's something to be considered. Now, one of the things that's become available are gene signatures that are being tested to try to identify patients at the highest risk. In other words, those that have an outcome closer to stage 3. These are the list of companies that are working on them, as well as there's studies looking at microRNA. Right now in the United States, the only one we have commercially available is Oncotype DX. Interestingly, the price of testing for whole genome sequencing is going to come down. There's the head of Intel was called Moore, and he quoted a Moore's law. He said that the number of transistors in a dense integrated circuit doubles every 2 years, and he predicted that this would lead to a decrease in the cost of gene analysis. And in fact, even if you look at Moore's law, because of next generation sequencing that came in around 2007, there's been a dramatic drop in sequencing and cost per genome. So in the very near future, probably whole tumor genome sequencing will come below $1,000. And most people think when that happens, it'll be available for just about everybody in the United States at that price point. Now the problem is we'll have probably more molecular data than we have clinical data to match that, and there'll be a lag before we know how to utilize this information. So one of the things about these gene sets, they look at large gene panels initially and they validate it against a data set, and then they prospectively look to validate it. The problems is that many genes often fall out associated because they're looking at large numbers. So most of the panels that are being looked at have very little overlap or commonality in genes. This is one 18 gene signature coloprint, very small study, 135 samples, but you could see how it did discriminate between high and low risk. Now, probably the one that is furthest along is the Oncotype DX, and this is a 12 gene signature, and they perform a recurrence score based upon weight for each of the different genes. And this recurrence score can give you an independent prognostic variable, independent of stage, independent of differentiation. Now, unfortunately, it does not give you information about prediction as to chemotherapy efficacy. This study is available in the United States and costs about $5,000, and at this time is not being routinely reimbursed by our insurance companies. You can see here that where the recurrence score fell out as an independent variable, the only other thing that did fall out was mismatch repair testing. You'll notice here that in this analysis, and this was done from a large Southwest Oncology Group adjuvant trial that was done looking at a vaccine back in the 90s. Now, the one problem with this assay, when you get the information, you try to interpret it. The discrimination between low risk, which gives you 13% relapse rate at 5 years, and what they would consider a poor or high risk of recurrence rate, which is 21%. There's only 8% between those two, so it doesn't discriminate very clearly those at the very highest risk of recurrence. It can give you some information. I think the best use of it is probably trying to persuade patients not to take chemotherapy. If they have very favorable prognostic factors, some patients are very keen to have chemotherapy. This can probably buttress your arguments and give them additional reassurance that they have a favorable tumor. So in summary, stage 2 colon cancers have overall favorable prognosis, but they're through pathologic assessment, you may identify some subsets that have a worse prognosis and therefore may have an outcome closer to stage 3 colon cancers and may have derived greater magnitude benefit from adjuvant chemotherapy. We don't have any data surrounding oxaliplatin therapy. This is all based on 5-FU chemotherapy. We do routinely test for microsatellite instability, and we do not offer adjuvant therapy for those that are MSI high. At this time, the role of molecular gene signatures and single gene mutation testing is evolving. I think it's probably not ready for prime time or not ready for clinical practice as a routine use. And the choice of chemotherapy for patients with stage 2 colon cancer, whether 5-FU alone or whether there's a role for oxaliplatin, remains controversial. Thank you very much.
Professor Christopher, thank you very much.